Hello everyone and welcome to your Tier 1 Enabling Care webinar. My name's Verity and I manage the StopFalls team at HCPA, and we're going to be connecting enabling care and StopFalls throughout today's webinar. And with me I have...
I'm Susie and I'm a physiotherapist and I've worked in complex care, neuro in the care sector for most of my physio career. And then I've been working with HCPA, well, as an external trainer for the past 7 years. And then over the last year and a half, I've been working alongside the StopFalls team as clinical lead to help with the StopFalls team and also to develop the enabling care framework of training.
Perfect. Thank you, Susie. Because we know that even though we're called the StopFalls team, we're not just about falls happening. There's a lot more around it, and that's what we're going to discuss today. So I'm going to share my screen. So we're going to go through today to show what HCPA offer within the StopFalls service and how it links with enabling care. So we're going to go through all of our resources so you understand your next steps to help support the organisation that you work for. And to understand the importance of prevention and what we can do to make sure we recognise deterioration quickly. As I said, it's not just about falls, it's not just about getting people to do more, but overall just keeping people well. So we want to let you know the next steps you can take in order to support the people you look after, and I'm going to go through with you all of our latest resources and training. So we're here because we're going to give an overview of enabling care and StopFalls and how they are both linking together. Because sometimes in care, we focus on what people are unable to do rather what they can do. So we must change this culture to enable people by having a questioning approach. We know that prevention is important, even more so since COVID-19, so we can protect those that you can care for from further deterioration. So we must enable people so that we can improve quality of life, prevent hospital admissions, and keep people well. Generally, falls prevention involves many things which are important for an individual's overall health and well-being. So we aim for care providers to have this preventative approach for all health and well-being and have an enabling care culture within their organisation. So we're going to kick off with straight away what we can offer, and then we're going to link some specific topics with our resources and education. So straight away, the StopFalls service has an organisational needs assessment where we would sit down with your manager or yourself and we build an action plan around prevention. So we look at what you have in place, where are there gaps, and generally we would put on a whole training plan for you so we can make sure that everybody's confidence and knowledge is up to scratch and make sure that everybody's doing what they should, what they're supposed to. And with that, we have open courses. So we've got lots of education running every single month in falls prevention, frailty for both staff and management. And management, we find really important to have these separate sessions because we let you know what we teach your staff. So everybody can be on the same page and have that consistent message. What we've started to run now after taking a break from running, but we are running our level 2 chair-based exercise instructor qualification. So somebody from your organisation can be that level 2 chair-based exercise instructor. And also we run a TAGO a qualification as well with Later Life, who specialise in exercise for older adults, and that very much is focused on strength and balance, and we know that strength and balance is the evidence in preventing falls. We have exercise videos on our website. So if you haven't gone onto our website, it's HCPA StopFalls. And we've got videos in chair-based exercise and standing and balance. And they start off nice and simple, and they start to increase in difficulty as the videos go on. And we've got 10 days worth of those. Now, demonstrations and exercise instructions are also on our free HCPA StopFalls app, which is available to download for free on both Apple and Android. And again, we'll talk through that a little bit more in the next few slides. But again, to get people moving, you can join us every Tuesday at 11 a.m. for around 30 minutes to take part in chair-based exercise with us virtually and with many other care providers in Hertfordshire, and also individuals in their own homes. And we have a whole resource library for you, and that is a website underneath the title, which you can click on, that takes you to our StopFalls page. And with that, we have our StopFalls general resource, which goes through our falls prevention resources, top tips to make sure we keep home safe, exercises, and also some guidance on nutrition and hydration as well. An enabling care resource as well, which we'll talk about throughout this whole webinar, but that's going to be your go-to guide on your next steps. Sit less, move more. So we know that physical activity has huge effects for absolutely every single person. But sometimes not quite knowing where to go next to get those exercise opportunities can be missing. But we've done all the work for you, so that's there as well. Keeping healthy at home, and that's another resource designed for people who like to take a little bit control of their exercise routine. So for people living in their own homes, but also people in care too, to follow exercises and instructions to keep moving. And also our latest one, Posture Friend, which has been designed by Susie for people that have learning disabilities. And the last one, as I've mentioned, is our free StopFalls app, but I can talk about that through a little bit more through the next slides. So we know a fall it's not just about that fall. It doesn't just stop there. Many things can affect somebody's falls risk, from posture management when sitting, neurological conditions, independence and mental well-being. We've got monitoring deterioration. It's important to know somebody's baseline. Internal and external falls risk factors, which we cover in our falls training and through our falls resource and the StopFalls app, to know those things that we must be aware of to prevent falls. Medication, nutrition, hydration, and UTIs as well can come into that. Equipment, sedentary behaviour, when somebody's accustomed to sit or lie for a long period of time. And lastly, if somebody has had a previous fracture, injury, or pain, we know that can increase risk of frailty and ability to carry out activities of daily living. There's lots of things that can contribute to a fall, and this is why we're trying to connect our education together and how this can link with our enabling care programme. So if we think about falls, a lot of those factors that I spoke about, it involves lots of different things, but we know that prevention is a way to combat falls and frailty too. We want to educate those who work in care about contributing factors to falls and frailty that allow staff to identify quicker, because then we can put the appropriate actions in place. Falls are the #1 reason older people are taken to the emergency department, and they cost £2.3 billion a year. Hip fractures alone account for 1.8 million hospital bed days and 1.1 billion pounds in hospital costs each year. And generally for those people that suffer those hip fractures, outcomes are generally poor following a hip fracture, with an increased 1 year mortality of between 18 and 33%. So we know that after that stressful event and injury, individuals do not have that resilience and may show new levels of frailty, and therefore will need more help, which can affect falls, can affect how much independence they have, again, linking back to enabling care. Falls and hospital admissions can increase, again, negative effects on daily living activities, such as shopping, such as walking. Again, all of this affects how somebody's able to cope with what they can do every day. We should always aim to improve people, not just maintain, always focusing on what they can do, not just what they can't do. Again, that comes through all the way through enabling care programme. And we aim as HCPA to help all adult social care providers, staff and families to benefit from using our StopFalls service, but to understand that it's not just about preventing falls. There's lots of other things that can come out of it, including what Susie's going to be taking through with you today. And frailty as well. So I mentioned frailty and it's linked to falls just before, but we know that with frailty comes different levels of dependence. So we have to put a focus on recognising individuals who are transitioning to higher levels of dependence. That can be because of sedentary behaviour, as it says at the top, independence and mental well-being, previous fractures, injuries or pain, a physical or mental stressful event that can cause somebody to be a level of frailty. So we have to make sure we are putting an emphasis on the identification of frailty. That is taught through our frailty education and also our falls education as well. So, you know, the open courses are there for you to put your staff on, or through targeted support by completing that organisational needs assessment to look where those gaps are. We want to make sure that all care providers are having this training. Frailty characteristics. Many people don't know that we look at the main frailty characteristics of weight loss, exhaustion, weakness, slow walking speed, and low physical activity. And all these things, they link to falls as well. So it's about connecting those dots, bringing everything together, that we're looking at that prevention, we're taking that prevention stance and that enabling care stance to make sure that we're keeping people well. With these characteristics, an individual can be more susceptible to falls. Falls is also a frailty syndrome. Again, we go through these syndromes through our training. We know that somebody who has multiple falls may need to be assessed for frailty too. Generally, those that are recovering from illness or injury are looking at becoming more dependent and increasing that risk of frailty. So we must make sure that we don't just accept it and we take that approach to say, well, why is this happening and what can we do about it? And one of your first steps might be thinking, well, actually, I need to get on this training, or I need to put staff on this training. And lastly, mental health as well, and independence and mental well-being. And it is documented that mental health has an intrinsic relationship with the level of dependence an individual has on another. We know that if somebody is struggling mentally, that their physical health may decline and vice versa. So NICE guidance, the National Institute of Care and Excellence, said that individuals who are identified as being most at risk for a decline in their physical ability and independence will also be at risk for decline in their mental well-being. And we know that if somebody is becoming more dependent, we want to be thinking about falls as well. We want to get there and prevent. So again, if this is something that you feel like could possibly be a gap, thinking about our education, getting in touch with us, thinking about if you would like to do an organisational needs assessment, to go through all this education, to again build that training action plan. That's what we're here for. And mobility. And mobility comes into everything I identified with falls. At the top, you can see in orange all those factors that were identified. And we know that poor posture and positioning when sitting, or if they're sitting in an inappropriate seat, can make it more difficult for people to stand up. And again, we're thinking about falls here. Can also cause falls from chairs. We know that some people with dementia who are mobile and risk of falls may need more strategies to be supported, which Susie's going to go through posture and positioning through enabling and care, and we'll give you some more information. But mobility is not just about, you know, being able to move well from the lounge to the kitchen. There's lots of things such as breathing and chest infections, because we know poor positioning can cause difficulty with that, which can reduce overall function and health. So again, it's about connecting mobility to somebody's, you know, everyday overall health, which can be part of prevention, and needs to be part of everybody's, you know, practice in care. We know that the evidence for falls is through strength and balance training. So actually thinking about the resources available to you, and on the app, we have strength and balance exercises. We have our Keeping It Healthy at Home booklet and our falls booklet, and Sit Less, Move More to get people moving. So if you're not sure on how to do this, again, you can come to us and speak to us about guidance, but use our resources. They are there for you to use. We want staff to be, again, taking that positive risk-taking approach, that enabling care approach to get people on their feet. Generally as well, with immobility can cause, you know, stiffness and pain, people not wanting to move, but looking at, you know, different ways we can goal set and positive risk, because we know if we can get people up on their feet, it's going to be way out than becoming sedentary. So there's lots here that mobility links with, and again, it's understanding that it's not just simply about people being able to mobilize better for falls, but generally every part of their life, and how it can connect to independence and mental well-being. So Susie, I'm gonna change over to your bits now. Okay. So let me know when you're ready for your slide.
I'm ready, and I'll tell you next when it's the news, when I want a new slide. Thank you. Perfect. So this is the enabling care training that has been designed to help change the ethos and the culture of staff and of management, to ensure that we all embed an enabling care approach in everything we do in all of our care practices. And a lot of the content, especially the practical elements, will be new to most people, as they are from a therapeutic perspective. Obviously, it's mine as a physiotherapist, but these are mostly really simple tips that we'll be teaching to help make a huge difference to the people that you care for. So the overarching aim, next slide, the overarching learning outcome, the overarching aim is to give you an overview of the 3 different levels, which we've called tiers of training, that have been developed for the enabling care framework. So tier 1 is this video and the enabling care resource booklet that Verity mentioned. And this is available for downloading from the HCPA website, but it will be printed as a hard copy in the very near future, so that you can actually have it to actually refer to But feel free to print it out yourselves anyway from now. And this video webinar, as Verity said, is to give an overview of the training offered. I'm going to talk to you about some of the main topics and how they're expanded and developed across the different tiers, and how to use the resource booklet as well. So tiers 2 and 3 have title roles so that the internal staff have recognition, and the health professionals also know who they are then and who to liaise with. So tier 2 is called the Enabling Care Facilitator, and it's for certainly all senior care staff and team leaders and that kind of role. There's also a manager's strategy webinar session as part of this tier, which is a two-hour long session which gives an overview of what staff are going to learn on tiers 1 and 2 and 3, and discusses how to support staff who've been on the training. And tier 2 staff modules are six modules of 2 to 3 hours, and we're at the moment discussing whether it should be 3 days. I think it's going to be 3 5 to 6 hour days, but staff have to complete all of the modules in order, and they have to be signed up for all 3 days or all 6 modules. So tier 3 is a slightly larger course. It's the physio support facilitator level. So that's the title of the role that the staff member will have. And this includes 3 days of HCPA falls prevention training. And it's ideally, what we envisage is it's going to be for 1 to 2 members of staff in each organisation. For example, people like moving and assisting trainers, team leaders, engagement leads, falls champions, that kind of person. And it consists of 13 6-hour days over a period of about 3 months. And 2 of these days are added on within that 13, and they're specific to the non-weight-bearing pathway beds. So people who are temporarily in a care home, for example, due to a fracture and a temporary loss of independence. So there's a specific 2 days for that. And this level tier 3 has coursework and assessments for the participants to complete. And it also includes the associate membership of the Chartered Society of Physiotherapy, which gives them insurance, legal advice. They get a 2 weekly physio magazine, which is always interesting for people to read. Plus it gives them opportunities to attend conferences and also other benefits that are too lengthy to mention here. And this tier also includes regular ongoing supervision by a physiotherapist, and that's 4 supervisions per year to make sure that they are using the information correctly as it was taught. And it also includes ongoing telephone support, so or a WhatsApp contact with a qualified physio, mostly me at the moment, as that's needed. So staff can ask questions and get advice as they need to on specific problems. And just to mention, staff can join any tier without doing the previous one. So if they wanted to go straight in at tier 3, then that's absolutely a possibility. They're able to do that. So next slide. So a background to enabling care. So for many years, you all know, it's been the culture, I think, in health and social care that tasks should be performed for people who are unwell or who are in need of care, as they're unable to do things for themselves. But things have been changing very slowly, haven't they? Over the last 3 decades, care has been revolutionised by the focus on addressing people's rights and choices and involving them more in their care. And this started to change with person-centred care in the late 1990s. And much more has changed with the advent of the Mental Capacity Act in 2005. And then the Care Act in 2014 has been focused on getting people to do more for themselves. And the drive is to further improve this delivery of care to one that maximises the potential of an individual to participate in their life, both in terms of physically as well as emotionally, mentally and socially. So all parts of a person, holistic care. And there's also been the the recent guidance on health benefits of being more active, as Verity was talking about, and being more empowered and independent by being more active. And this came from the government's Chief Medical Officer's report in 2019. So this has been behind lots of the changes that are getting people up and moving more. And we know that through an enabling approach, people can actually improve. Now, this has been known in the therapy settings for a long time, of course, because essentially a therapist's entire remit is to help people improve. That's what we're paid to do. So now with this training, what we're hoping to do is to bring some of the information and skills that have previously been unique to qualified therapists. And we're talking, as I said before, about simple strategies that staff can use to help enable people. And this we're trying to share across the whole sector through this fully funded training. I think that's important to know that this training is fully funded because HCPA get funding to do that. There's a specific version of this training as well that's called Posture Friends, and Verity mentioned the resource. And that's also fully funded, and it's available through HCPA for the learning disabilities sector. So next slide, please. What is enabling care then? I mean, there's several terms which you would have heard, like re-ablement, intermediate care, rehabilitation, and some companies have certain teams that do these things, but there is no real clear definition, except for one that the NICE have specified and stated in 2017, which actually only refers to the intermediate care teams, and that is what it says here: assessment and interventions provided to people in their own home or care home, aiming to help them recover skills and confidence and maximise their independence. However, whilst there are teams actually that go out and do this, there isn't really any clear guidance on how to create this enabling care approach and this enabling care culture, especially in terms of physically enabling people. People often know that it's important to set goals, but what seems to be lacking are the skills required to help people physically to get from where they are now to actually achieve their goals, for example, to be able to independently walk to the toilet, for example. And it's also worth thinking about that there are lots of ways to enable someone. Whilst offering encouragement and taking time to assist a person to mobilise is clearly enabling, the smallest of interventions can also be enabling, and Verity did touch on this. So, for example, reducing pain for somebody by repositioning someone who can't move themselves independently so that their knee isn't twisted, or, for example, spotting the signs of a chest infection early and thereby preventing that person from needing to go to hospital unnecessarily. This clearly, in the first example, enables somebody to be pain-free, and in the second example, to potentially have a better chance of receiving early treatment so that they don't worsen and potentially die in the second example. Next slide. So the Hertfordshire County Council's Connected Lives framework. We're very lucky in Hertfordshire that we have a council that paves the way, a county council that paves the way in terms of these things. And the principles are about connecting people, preventing problems, enabling and supporting them, which is exactly what enabling care and the enabling care training is principles are. Next slide. This is going to show you. Oh, that came up separately, but there you go. Next slide, please. Oh, no, that's it. Sorry. So the principles of an enabling care approach are, in order to improve the well-being and quality of life of someone, they maximise the potential for somebody to improve through choice, empowerment, independence, and positive risk-taking. And more than anything else, it emphasises the concept of a questioning approach. And we encourage first and foremost for staff to question things rather than simply to accept that things are the way they are and they're going to stay that way. So asking questions by using tools such as the NHS 5 Whys, which we'll talk about in a minute, can help people to find out the root cause of a problem, and we can help people therefore to do more easily and do more effectively by finding solutions to those problems. Next slide. So what are the benefits of an enabling care approach? Well, to the individuals you support, that's pretty obvious. I think we've talked about that so far even. So quality of life improvements, increased independence, improved health, reduction in pain, improved confidence, being more empowered, preventing deterioration, and less unnecessary hospital admissions, to name even just a few. And the benefits of staff, well, that's interesting, because they actually seem to feel more empowered and rewarded. They report having more time to do their jobs and feeling more valued, because they actually feel good when they make a difference to people's lives. And one of the biggest effects, and we've had quite a lot of feedback from the physio support facilitators, because enabling care started with tier 3 about 4 years ago, and we've developed the other levels since then. But the physio support facilitators have actually reported that their work is physically easier. So that's a huge benefit for staff. And the benefits to your organisation are cost savings, reduced hospital admissions, improved KPIs, including reduced falls, reduced call-outs, as well as improved CQC inspections, and also better marketing opportunities. So a better reputation. One example where we have to facilitate physio support facilitators is that they report improved relationships with health professionals and improved confidence among stakeholders. So their reputation is improved. And then, of course, the benefits to the wider system are things like cost savings, reduced hospital admissions, reduced falls, reduced call-outs, and more resources are freed up for other care needs, better overall care provision, and all of these, of course, mean reduced costs across the system. Next slide. So the resource booklet is actually called an enabling care approach, and as it says there, to change the culture across the care sector. And it's an education resource for anybody involved in the delivery of care. And as we said before, it's available on the website, and it covers most of the topics here, and really is designed to be used as a reference guide for all staff, for managers. It just sets things out in hopefully in a very clear way for you to use as a reference. Next slide. So I'm going to give you a bit of a whistle-stop tour through some of the key themes that are involved in the enabling care training framework. Next slide. The first is mental capacity and how it links with safeguarding. So most of you and your staff will have had training on mental capacity, and you understand the importance of giving people choice. But you've probably also had experience of how difficult it can be, one, to establish whether someone has capacity to make a decision in the first place, and two, to ensure that we don't put that person at risk at the same time as giving them choice. We are expected to ensure people are safe, and sometimes this can cause a dilemma. So how do we ensure somebody's safe and is able to make decisions for themselves at the same time as being safe? Of course, the answer is that we can't always eliminate the risks. And certainly so what we teach on the training is that if a vulnerable adult has capacity for a decision, it's abuse to make them do something that they don't want to do, or to make a decision for them against their wishes just because you or another healthcare worker or professional thinks it's the right thing, or because you think it's safer. And of course, it's also abuse to make a decision for someone who lacks capacity when the decision and the action taken is not in their best interest. Everything has to be documented as in the person's best interest, regardless of who is making that decision. So an example of this we give is that someone who has diabetes who wants sugar in their tea, if they have capacity and understand the risks, you can't stop them. You can't even actually try to persuade them, because that would be coercion if you're trying to persuade them not to have sugar. Whereas if they don't have capacity for that decision, if they don't understand the risks of having sugar, you'd actually be negligent if you did put sugar in their tea, if that makes sense. Next slide. So the key messages with regards to mental capacity and safeguarding are some of the things that are not always taught well or understood well. So we try and cover them a bit more in enablement care, because it's fundamental to the enabling care approach. One important factor is that we are only permitted to question capacity in an individual with an impairment of the mind or brain. I had an example of a lady with a pressure sore and a sunken pressure mattress. And I had a discussion with a tissue viability nurse who said, this lady is refusing to have a mattress changed, so I need to do a capacity assessment. And I said, okay, I'll help you with that. So I started filling out the capacity assessment, which I'd developed. And the first question on the form was, does the person have an impairment of the mind or brain? If not, do not continue with this assessment. Quite rightly, that's in line with the Mental Capacity Code. This lady did not have an impairment of the mind or brain. In fact, she had a musculoskeletal condition, which meant that she wasn't able to care for herself. So we actually had to document that we'd informed her of the risks and that she decided to keep her current mattress. We couldn't even complete a mental capacity assessment. So those kind of things we're talking about. We also emphasise assessing capacity using the 4-question test. And also talk about staff referring to the right professional to do this. For example, if they don't know the risks and benefits of a decision, for example, if they don't know the risks of taking a blood thinning medication, for example, and the person's refusing to take their medication, then that needs to be referred back to a person that does know the risks of taking or not taking that medication, such as the GP, but it could equally be a nurse, to assess whether the person has capacity to make that decision. And also, people often think that best interests are what is good for a person, regardless of their capacity to decide for themselves. So we clarify that best interest decisions are only for people who lack capacity to make a certain decision, and that all parties, including lasting power of attorneys, also have to act in the person's best interests. And if they are not doing so, then that needs to be reported to the Court of Protection. And we also talk about the importance of ensuring decisions are documented, risk assessments in place, and as Verity touched on before, and I mentioned, having a questioning approach. Next slide, please. So a questioning approach is probably the most important theme throughout the enabling care training. As I mentioned before, we always promote the overarching ethos of having a questioning approach, because even if this means needing to challenge others' actions, we may be needing to question something in order to empower the service user and to prevent abuse, and thereby safeguard a service user or an individual. A questioning means basically that we don't accept simply what's always been. I think you've gone on too far with those slides, Verity. Going back a bit. Oh, maybe not. Okay, fine. And that we can't change things. So we don't want to always accept this is how it is and it's not going to change. We need to look to determine what the problems are, what the barriers are, what could be better, what could be improved, and what could the person do more easily, more effectively. So we ask for managers to support their staff to foster this questioning approach, because it may be that it highlights the need for more training, but at least it means that things won't just go by unnoticed until something goes wrong. So as we're on this slide, the NHS 5 Whys, some of you will be familiar with this tool, and basically it encourages a questioning approach because it aims to establish the root cause of a problem rather than just accepting what's happening. So an example of a root cause analysis using the 5 Whys could be something like, Joe was not mobilising to the toilet. Why is that? He'd lost confidence. Why had he lost confidence? Well, could it be that there was a problem with his frame, for example? Why was that? Well, that was because nobody had audited and checked the frame, and it felt wobbly when it was checked. And then you see we can start to address the actual issues, which might mean that things are changed for the better, and then we can get Joe to be a bit more confident with his walking, for example. It's really about changing the way staff are thinking so that we can, so that we're considering how to improve things. As I said, not just accepting that this is how it is and that's how it's going to stay. Next slide. And of course, this may take less than 5 whys, or it might take more. So the next theme is posture and positioning. And this is obviously, as a therapist, this is a major part of the whole program. So in tier 2, we teach basic anatomy and physiology, which is in more depth in tier 3. And this is vital for understanding, for example, the alignment of joints, the effects of poor positioning and the problems that may arise, and enhancing staff knowledge so that they can spot things that go wrong or that are deteriorating, so that they can signpost more appropriately and in a more timely way, and so that they can communicate issues more professionally and confidently with health professionals. Next slide. Oh no, it is that slide. I think I haven't written much on the slides that are the title one. So posture and postural alignment, go back a slide, thanks, means the position of someone's body, for example, lying or sitting or standing. And we talk about this from a real life self perspective when we're doing the training, and we get participants to understand what this means and how it feels by doing lots of mini practicals. So one example is showing them how it feels to blow up a balloon from a slumped position compared to blowing up a balloon from a sitting up tall position. And it gives them a real good idea of how difficult it may be for someone to take a deep breath to cough and to clear their chest in a slumped position. And of course, what obviously is the main point is that a cough is required to clear our chest, to clear our upper airways, to protect our airways from getting an infection. So in terms of chest infections, being able to take a deep breath and cough is absolutely vital. So next slide. So we talk about the benefits of good alignment. And again, you can click it. So being able to move more easily, being able to perform functional tasks more easily, being able to be more independent. Good posture allows people to be able to swallow and eat and drink with less difficulty, to communicate even. So speech is easier when you're positioned in a better position. And to be able to access the environment. So for example, being able to lift the head to see if somebody's got a tilt in space wheelchair, for example, and to be free of pain. And of course, we also teach about the consequences of poor, non-optimal positioning. So the reduced ability to move functionally, being unable to lift an arm to reach a drink, if it can be that obvious. If somebody's posture is better, they can reach for their drink. And if they're positioned in a bit of a crooked position, they can't reach for their drink. Being able to sit to stand or unable to sit to stand if somebody is in a poor position. Reduced independence because of all of this, difficulty swallowing. So it's the opposite to the benefits of being positioned well. So problems with eating and drinking leading to increased risks of aspiration pneumonia, difficulty communicating, pain which impacts on quality of life, on motivation, as well as requiring pain relief medication, which can also have the known side effects such as constipation. Muscle shortening and contractures are very common if people are positioned poorly, and these lead to, in turn, even more difficulty with positioning. Pressure sores is an obvious one, so lack of repositioning or positioning in certain positions can have an increased risk of pressure sores. And as I said before, breathing problems and chest infections, all of which potentially lead to safeguarding concerns and, of course, potentially to deaths. Next slide. So we look at various postures, including sitting posture, and peak is an example of a tool that staff can use. This is in the resource booklet and in the training. And we get staff to use this to check posture. So is the person evenly positioned? Is the pelvis in a neutral position? Is there equal weight on both buttocks? And is there a 90-degree angle at the hips, knees and ankles, and other knees facing forward. So that makes up your acronym of PEAK. So it's really easy for people to remember. And often staff will assume that they can't change things. In tier 2, we get participants to start looking at postural alignment, checking whether somebody's pelvis is positioned well. And in tier 3, we do more, and we teach them more about noticing and changing positions to improve them. Asking, is this posture good? If not, can we reposition it? This may even include or involve rehoisting someone, or do they need professional advice from a physio or an OT, for example? We talk about repositioning often, and about ensuring joints are in good alignment, supported in good alignment with appropriate equipment and pillows when necessary. And we also talk about positioning in bed, but also thinking about whether anyone who's cared for in bed, questioning why this might be the case, whether this can be addressed so that the person can spend time out of bed. And there's a big piece of work being done at the moment in the community teams that's aimed at bed prevention. And this will also be very useful, and it will complement this training. Next slide. So next is activities of daily living and personal activities of daily living, we all know as addles and paddles, and encouraging independence and empowering people to be able to do more for themselves is obviously another key theme of enabling care. I mean, this is what therapists do all of the time. Next slide. So what we're trying to do is to get staff to think about how they're changing and how they're encouraging people to do more and be more involved in their care physically, as well as, of course, being part of the decision making around their care. So I think I might have gone past the slide here. Hang on a second. Have you gone further than, go back one, Verity. Yeah, that's it. So more than anything, getting them to do with somebody, not do for, not to assume that because the person can't do something today, that they won't be able to do it in future. And of course, it is tempting for people to do something for someone because it seems like it's an act of kindness, and it may also appear quicker for staff to do it rather than to assist the person to do it for themselves. In the short term, of course, this may be true, that it is quicker. However, as the person becomes more able, and we gradually then reduce the assistance we're giving them to perform a task, the service user might eventually be able to do the task independently. And when the staff start to see this, they'll feel that they've actually achieved something because they've actually truly enabled somebody to do things. And then they'll be able to do something else while the individual does that task themselves. So we talk about making things into a meaningful activity, such as walking to the kitchen to choose a meal, which gets somebody mobilising at the same time as doing something useful for themselves. And making sure that people are being cared for, that people being cared for continue to have access to objects that they may have used when they weren't receiving care, so that it continues their understanding of how to use those objects rather than losing them, as people may do when they have dementia, for example. Next slide, please. So this, as we just saw flashed up a minute ago, is the More to Less support tool. And we encourage staff to consider working through this example or using this tool from red to green or green to red, depending on the person and the person's needs and abilities. So usually they start at what they think the person can do and work up or down the levels from there. So it needs a little bit of thought and focus initially, because it isn't about what they, isn't just that they can or can't brush their own hair, but it's how a physiotherapist would work, for example. Seeing if somebody can brush their hair with verbal prompts alone might be followed with, if they can't do it, placing the brush in the person's hand initially and starting to brush the person's hair with them. Then slowly reducing that help as the person starts to engage and join in. And then the person may be able to do it with less help, even in the same session. It might be the case, though, that each session is the same for several times, and then eventually the person starts to be able to do these things more for themselves. And even if they don't end up doing something totally independently, they're still doing more than they were before by joining in. So it's about continually giving opportunity to engage with activity. And it requires a really positive, encouraging and patient attitude. But it is, as I said, it's part of what therapists do in order to help people improve, because that's our job. So next slide, please. Across the tiers, we teach therapeutic handling, and this is from a practical point of view. And in the tier 2, at the moment, we are doing the virtual training only, but we are offering a day where we catch up on doing the actual practical elements of the training. But we do demonstrate these throughout the tier 2 anyway, so that staff can see. We've got one of those Facebook portals, so you can see the whole room. And we include teaching about how the body moves when there's no impairment. So this is called normal movement patterns. And these tap into the way our bodies have evolved to do things in the most efficient way possible. So we look at how to enable people physically, having a better idea of how and where on the body to touch, for example, to get the best outcome with the least effort. This is how therapists are able to get people to do things more easily than people that are less skilled at handling. And I think that's one of the biggest things in my career. I have heard staff say, how come you can do that? How come you can do that and we can't do it? And we're trying to teach some of these skills. We can't obviously teach complex handling skills, but we do try. What I am trying to do is to impart some of the skills that will help staff's ability to enable people they care for with specific tips and techniques that are simple to learn. And these manoeuvres include putting a foot on a foot plate. Sounds really simple, but people have done this with much effort in their career. So this is a bit of an eye-opener for people. And also sit to stand. Staff are always amazed at how much easier this is made by very simple techniques. And then we do lie to sit on the edge of the bed. We look at rolling in bed, we look at transfers, we look at mobility practice and range of movement. And then and some of these are in the tier 3 module, so facilitating an exercise program that's been prescribed by, for example, a community physio. And the emphasis throughout therapeutic handling is on light touch, less is more, and less effort, not only for the staff member, but also for the individual being cared for. Next slide. So another big one, they're all big key themes, aren't they? So onto the benefits of movement and physical activity. Next slide. So firstly, we talk about the effects of a lack of movement and activity. And there is increasing evidence that sedentary activity among the older population is becoming more of a problem. Figures actually show that a lack of physical activity is the cause of diabetes, high blood pressure, obesity, coronary heart disease, stroke, and other conditions that affect the blood vessels. And physical activity is the 4th leading risk factor for global mortality. So the most recent figure is sitting at about 3.2 million deaths per year globally. So basically, we have to get people up. The risks are totally outweighed by the benefits, and being sedentary is increasingly termed as a sitting disease. So we have to do everything we can to get people standing at least. And this also helps reduce falls. Next slide. And we go over the new chief, well, new, they're from 2019, it only seems like yesterday, the Chief Medical Officer's guidance, emphasising that light activities bring huge health benefits compared to being sedentary, with more activity bringing greater improvements in physical function and in the prevention and maintenance of many diseases, as well as in improvements in mental health, confidence, and even reduced feelings of isolation, for example, from people exercising in groups, such as the virtual groups that HCPA run. And I'm sure this also is felt in an online group that people are in a group. So the main messages are some is good, more is better, and starting at the appropriate levels for the person, for each person, and also referring to the right health professional, usually a physio for this kind of thing, where appropriate. So, of course, physical activity is, as I said before, one of the fundamental aspects of an enabling care approach. Next slide. Another important area is equipment and mobility aids. So the aim here is to give staff more awareness of some of the equipment available to help people be more independent and more functional, and basically to enable them to do more, such as a quick move or a SARA SETI, which helps people, both of those help people who can only stand briefly to be able to be transferred in a perched sitting position, and or to be, you know, to get their clothes on in a standing position, but safely. And since care staff are in regular contact with the individuals they care for, and they often know them very well, they are often the people to notice when needs change, and they can signpost, and we encourage them to signpost when required. And we also talk about the fact that in order to enable people, staff have to question things, whether they need, you're going backwards and forwards, go back one. Whether they need their needs, or whether their needs change or need reviewing, and who they can refer to. So for this area, physios are most often the key allied health professional to involve regarding the appropriateness of mobility aids, whereas an occupational therapist is often the key person to involve, not always, but often, regarding the appropriateness of other equipment. And these professionals have been trained to weigh up the advantages and disadvantages of each piece of equipment, so they're able to assess the service user's needs appropriately. So we're not asking staff to assess people's needs and what equipment they need, but to spot when they might need something different. That's the point. Next slide, please. So an enabling care approach gets people to question the use of equipment. And that could be that although if for example, a piece of equipment has been issued to a person, and that may be that it was appropriate for their needs at one point, but it may be that it's no longer appropriate. So giving an example, did you know that using the arms to pull up from a chair actually switches off the leg muscles? So unless it's the only option, it may actually be disabling somebody because it promotes the use of the arms and not the legs. So one example of this would be somebody who comes back from hospital after a period of being unwell, and they're, instead of being independently able to stand as they were before, they're now using a rotor stand, for example. And our normal movement pattern for sit to stand is to use our arms to push up, and this engages the muscles in our legs to push up from the chair. And if you're listening and you're wondering what I'm talking about, try it right now. First, pull up using your arms, using obviously something sturdy that's not going to break, to pull up on, and check how much your legs do or don't do, compared to if you use a normal pushing up from the chair motion. And when you do that, you'll see that when you push up, your legs actually engage a lot more. And staff need to be supported to question these things, of course. For example, with the person with the rotor stand, they may need to then start practicing sit to stand. Initially, maybe just getting the person to push with their arms to lift their bottom a couple of inches off of the chair. And alongside that, keep carrying on doing work with the rotor stand, but also getting them to engage their legs. So then that hopefully that person will improve and get back to their previous functional level once they're home and in a safe environment and they're well, medically well. And things like the scenario where a person can walk to the bathroom but is always transferred with a wheelchair. Is that person likely to retain their ability to mobilise, or are they likely to lose it? I think that's pretty obvious. Next slide. So the last next slide, sorry. Thank you. The next last main theme is about noticing signs of deterioration and preventing things from getting worse. This applies to the acutely unwell person, as in somebody who's become unwell with a chest infection, as well as someone whose posture has deteriorated and who needs referral to wheelchair services, for example. So keeping people active, healthy and independent is one of the main aims of a enabling care approach. And one of the important ways in which we can enable somebody to remain well, as we talked about right at the beginning, is through early detection of acute deterioration, which may avoid an unnecessary hospital admission and an unnecessary potential death. And reducing hospital admissions has been a focus of the care commissioning bodies for many years, because of course this reduces the strain on an already overburdened NHS. Next slide. And one of the main things we focus on is what staff are already picking up, that they already know, but they're not necessarily particularly confident about. For example, they may have smelt an odour that they think could be a chest infection or a urinary tract infection, more likely, but you can smell a chest infection as well. And here we're talking about the signs that someone's unwell, even a bit off colour. And your staff who know your service users very well are really good at spotting these things. We get them to make sure that they notice these observations and report them, document them and monitor and refer the service user appropriately. We encourage services to implement regular baseline observation checks on all service users, and also about the importance of purchasing the equipment to take vital signs. So we teach an awareness of vital signs: temperature, heart rate, respiratory rate, blood pressure and oxygen saturations, and the importance of using the News To and Restore To tools to guide what actions to take and to make sure that more timely and appropriate calls are made to emergency services, for example. The Enabling Care Facilitator role, Tier 2, Module 5, and Day 5 of the Physio Support Facilitator, Tier 3 level, covers this, and HCPA also offer open courses on vital signs training. And I know that some of the CCGs and district nurses are doing this training as well. So we're all singing from the same hymn book regarding News To and Restore To. But I'm going to just talk a little bit about the News To just introduce it if you haven't seen it before. On the next slide. Oh, yes, that's it. So this is the National Early Warning Score. News To. It's been updated in 2017, that's why it's called News To. And it's reproduced from the Royal College of Physicians. And I've included the next couple of slides just so that you all have a visual about what I'm talking about. So this is the News To scoring sheet, which looks at scoring someone according to their vital signs when you add them up. So down the middle, the 0 is the normal values, and what you actually do is you add the score to get a total depending on each of the vital signs. Next slide. And then depending on their score, this chart tells you the category of urgency that the person falls into, and then, next slide, the most appropriate response. So the responses here have been adapted for care settings so that, for example, calling the registrar may now be referred to the local prevention of admission services, for example, with somebody of a score of 5, so where they're in the moderate category. It really gives a very clear guide on what people may be doing already in terms of when they're referring to GP, for example, or for 999, but it means that they can do it more confidently with evidence to back up their decision. And I think this is why this is so key at the moment, to make sure that hospital admissions that are unnecessary are avoided, but then where they are necessary, that they are prompted much more quickly. Next slide, please. So the Restore 2 tool was developed by NHS West Hampshire Clinical Commissioning Group to support homes and health professionals to recognise more soft signs. So this talks about swelling in the hands or changes in urine, for example. Next slide. And it also handily has the news escalation tool on the back. The only thing it doesn't have is the news the score chart that I showed you first of all. But that is in the learning resources, not the learning resources, the resource booklet. And it's also, the News 2 tool is also on the HCPA website as well. So with regards to, next slide please. With regards to that, so that's with regards to acute recognition of acute deterioration, but also we talk about recognising and managing the signs of chronic deterioration. So we encourage staff to be independent, to be observant with regards to changes, not to assume deterioration is inevitable, to question whether something or someone with more expertise may be able to help somebody to improve, to keep up to date with training that includes enablement skills such as this, postural alignment, information on specific conditions, particularly neurological conditions and respiratory conditions, because we have so many more strokes, for example, at the moment. And to ensure their approach is supportive and understanding, and to use their understanding and compassion. And most overarchingly, to always question and to notice anything that's worsened or anything that is worsening, even if that's expected in terms of communication or chest infections or swallow. And the other things like posture, mental health, pressure sores. And we also talk a bit about specifics. So neurological patients, I should say, I say patients as a physio, but neurological service individuals that you care for, their care plans. So ensuring that splinting and positioning, including positioning aids, as well as how they're assisted to do or they're encouraged to do their ADLs, making sure that care is enabling. For example, encouraging use of the affected side, ensuring that there's regular reviews by physios and OTs. And for eating and drinking, that there are regular swallow reviews if needed by speech and language therapists. And that, for example, medication is regularly reviewed, for example, for tone, for spasms, for pain, that sort of thing. And next slide. Throughout the whole framework, we talk about who to signpost to for different issues so that staff know who and what is available. So the next 3 slides, starting with this one, show the chart that is available in the resource booklet, as we talked about. And it has the roles of different professionals with different, so different problems. So it's just worth flicking through those, Verity, I think. So, and picking out some examples, say, bowel and bladder dysfunction. So that would obviously be district nurse or continence nurse or the GP. Obviously the GP is a one-stop shop in some ways that we can refer to, and then they can refer on. But if you know who to refer to, then you can help with that decision. So the only other thing to talk about, thank you, next slide, is outcome measures. And this is really about monitoring change and monitoring improvements, which is good for you as a service to demonstrate to CQC and to the monitoring teams about the progress you're making. And it's vital for us as HCPA to demonstrate what's working in terms of getting funding for training projects that actually make a difference to the care we provide. And this slide shows some of the outcome measures that are currently being used. Some of you will recognise some of them on there. I mean, most of you will already be measuring or documenting hospital admissions, number of falls, number of pressure sores, for example, and the things that are falls and frailty specific, such as the FRAT and the PRISMA, the Rockwood Clinical Frailty Scale, the timed up and go, and the gait speed test, just to mention a few. But then there are other patient-reported outcome measures, which are a really good way to get a complete and relevant picture that's specific to the person. So they're the ones that the patients report themselves, or the individual being cared for reports themselves. And the community teams, community therapy teams, use the patient-specific functional scale. It's on the System 1, if any of you use that. And they also use quality of life ones like the Short Warwick Edinburgh Mental Wellbeing Scale. So it's worth asking the therapists about those things and being able to monitor change with people. And another important outcome of training is whether outcome measures that we teach are being used. So, for example, the News 2, is that being used? We need to be monitoring whether this is useful. And at the moment, this is a bit of a work in progress, because HCPA, as some of you will already be aware, are working on the prevention standards, and this will be much more comprehensive, and it will include a lot of the outcome measures and ways that you can evidence your brilliant care, which you're going to be having after you've had all your staff on the enabling care training. Thank you very much.
Okay, thank you, Susie. So a lot of information there with how we can support you and your organisation. So again, the best thing to do is make sure that you get in touch with us through training, through HCPA website or the StopFalls website. All of our details are on there to start to implement those next steps. But we want to be doing not just one thing and think it's all covered. We want to be making sure that our open courses are being attended, but as well as these programs to really make positive change, not just for preventing falls, but generally keeping people well, increasing quality of life, as we know is not so simple after everything that Susie's gone through with you today. So I hope it's been enjoyable, and thank you to Susie as well for all of her input.
Thank you.
Thank you very much.
Thank you.